Hello and welcome to the Check Rare podcast. My name is Peter Suzuki, and the topic of today's discussion is Alpha-Mannosidosis, a rare inherited lysosomal storage disorder. This is the third of a four-part series focusing on Alpha-Mannosidosis, and today we'll be talking with Dr. Markey McNutt on the challenges of identifying and caring for patients with this rare disease. Dr. McNutt is a clinical geneticist at the University of Texas Southwestern Medical Center in Dallas. Hello, Dr. McNutt. Thank you for your time today. Can you introduce yourself and tell us about your work?
Hi, I'm Markey McNutt. I'm a clinical geneticist at the University of Texas Southwestern Medical Center in Dallas. And today I'm going to discuss alpha-mannosidosis and my own personal clinical experience. All the views expressed are my own and don't represent my institution.
What is alpha-mannosidosis?
So alpha-mannosidosis is a very rare genetic condition that results in the loss of a specific enzyme called alpha-Mannosidosis. And that's an enzyme that's important in the lysosomes for breaking down oligosaccharides. And so the loss of that enzyme leads to accumulation of those abnormal chemicals that then lead to a lot of diverse clinical features. So it's a very rare disease. It's been estimated that it only affects somewhere between 1 in 300,000 to 1 in a million individuals. And it's a result of genetics. So there's really nothing that you can do to prevent it. It's just one of those things that gets inherited. And the clinical features are fairly diverse. We separated into 3 subtypes, type 1, type 2, and type 3. And that's really based on when the symptoms occur. Type 1 we consider as being more mild because it starts later in life, usually in later childhood, and has less severe symptoms. The type 2 is more intermediate with symptoms in early childhood, and type 3 is most severe with symptoms occurring sometimes even before birth.
What are some of the signs and symptoms of this rare disease?
The symptoms that we can see are wide-ranging. They affect many body systems. One of the most common features that we see is hearing loss. Most children after age 3 are affected with hearing loss in both ears, and that can often be the first sign of the disease. As development progresses, we start to see problems in school and intellectual disability, and the skeleton is pretty significantly affected. The bone density is typically low, and patients get degeneration of their joints, which affects their mobility and their fine motor skills. We also see effects on the eyes. Patients can get corneal clouding, cataracts, and effects on their retina. Another feature of the disease is immunodeficiency. Patients will get recurrent infections. Ear infections, upper respiratory infections are very common in childhood.
How many people have alpha-mannosidosis?
I think going from the prevalence data, there's probably 300, 400, 500 in the US, I would expect. One of the issues is that there are mild forms of this. And so there's almost certainly people that we've missed. And so I think it's important to, again, keep in the radar that if something doesn't make sense, patients that have really early onset issues like the severe orthopedic issues, getting them to genetics, may be able to identify these ultra rare diseases and allow us to offer them treatments that are now available.
What treatments are available for these patients?
Well, in the US, we haven't had many options. In the past, one of the things that had been looked at is bone marrow transplant. That's something that's been used for many lysosomal storage disorders. It has been tried in alpha-mannosidosis, but you have to do it fairly early before you see significant neurologic signs of the disease. That's, of course, a risky treatment. And the long-term outcomes are still under research. Now there is an enzyme replacement therapy to give back the enzyme. That's been more recently approved in the US. It's been approved in Europe prior to that. And the hope is to slow progression of the disease. But again, we really need long-term outcome studies to see what the full effect of that treatment will be.
How often do you follow up with patients?
Because we didn't have a lot of very effective specific treatments, we had not been seeing patients very often, maybe every few years, to make sure that they have gotten to the subspecialists that they need, that if they have any new disease manifestations, that we get those addressed appropriately. Obviously, physical exam and history are most important, so we can identify those new complications that an individual may be experiencing, and get them to the right subspecialist to evaluate that for treatment. Certainly, functional tests later on, things like 6-minute walk or 3-minute stair climbing tests, pulmonary function tests, can be used to assess their functional status. Evaluations by physical therapists for functional abilities. Hearing exams serially are important. As soon as they're diagnosed, we expect most patients will develop hearing loss, so identifying early so that they can get appropriate therapies and adjust their learning plans. Other management that we do is of course routine blood tests, checking routine chemistries and blood counts. We check their oligosaccharide levels, and on their initial diagnosis, we'll often check their enzyme activity, just so we have a record of it.
How do you measure that a patient is improving once treated?
It's very, very difficult to very objectively review that. We can look at something like oligosaccharides, which we know is the biochemical marker of the disease, but that doesn't necessarily correlate with their clinical outcomes. So it's really what the patient's reporting and how they're feeling, how they're functioning on a day-to-day basis. Formal tools for assessing patient quality of life and those sort of things have been developed, but in terms of in a busy clinical practice, actually applying those are very difficult. And so most of the time, I think it's just how the patient or the caregiver feels like the patient's doing. There are things like the 6-minute walk or 3-minute stair test or pulmonary function test where we can see objectively that there's either no change or there's been an improvement or there's a decline. But that's only one dimension of the disease. And so I think it's very difficult to overall assess that. We expect in this disease to see a universal decline over time. And I think that just seeing no progression is a positive outcome. Sometimes we can't reverse what has occurred already, but that stabilization can really be a benefit for patients.
Who is part of the care team when treating patients with alpha-mannosidosis?
Sure, of course, their primary care doctor is very important for guiding care. Generally, genetics is involved to do testing, disease education, follow-up testing of family members. We see ENT involved because of the hearing loss, audiology. As these patients develop orthopedic issues, we see them seeing orthopedics, physical therapy, occupational therapy, physical medicine and rehabilitation, physicians, of course, ophthalmology for the eye concerns, neurology, as these patients do develop ataxia many times, as well as a myopathy that causes progressive weakness. The tip of the iceberg of what can occur, we see all of many other manifestations, including endocrine disorders, so endocrinology, pulmonary issues, so pulmonology, sleep medicine may be involved.
Who should lead the care team?
I think ideally it should be the primary care doctor, although many times I think it is genetics, as we're used to rare disease. I think it can be overwhelming for a primary physician to learn a new disease that they may not have been familiar with. So many times it is genetics that's helping arrange some of that.
how do you handle the transition of alpha-mannosidosis patients from pediatric to adult care?
In my own practice, we have set up a transition clinic where I see patients as soon as they become adults. They're handed off from the pediatric geneticist, really to help facilitate that, because the family's facing a big challenge. They have all of these subspecialists that they see, and and most U.S. practices, that's separated below 18, above 18, and so they face this challenge of needing not just one new doctor, but potentially a dozen new doctors, and really helping them identify people that can help them as they make that transition. Can really help the family because they can be kind of lost there, faced with so many changes, as well as changes in insurance. When individuals reach 18, they may have a change in insurance, which can also affect their care. So really navigating all of those changes is very, very important, and it's a point where patients can really get lost to follow up, and we really have to do a better job of being intentional in moving patients from the pediatric provider setting to adult provider settings.
What would you like physicians to know about this rare disease?
Well, I think as we have done more genetic testing, a lot more rare diseases have come to the forefront, right? We're finding these things more often. And I think we run into this in many different disorders, not just this one. And the key, I think, is not to educate every primary care provider about each one of these diseases, but more to get across the message that, there are other subspecialists like genetics that deal with rare disease. And when you come across something that looks complicated, that looks syndromic, that looks like it might be genetic, you might not remember the features of every one of these rare diseases, but remember there are physicians that are there to help with that diagnosis, and identifying those individuals in your practice setting can help you to get those patients to somebody that can help you with diagnosis, so that you don't have to remember every single feature of every rare disease.
What would be your message to newly diagnosed families?
I think it's really to emphasize that they're not alone, right? That there are other people that are dealing with not the exact issue, but similar issues. The kids have the same disease, and they're going to have a lot of shared experience. So, trying to find those resources, patient groups, support groups, can be really, really vital to providing the support that families need as they face the challenges of a diagnosis of a lifelong chronic condition.